We'll talk about the history of ADHD very briefly. It will be a fun, brief review. We'll talk about the basics of ADHD because we have to. We'll talk about the treatment of ADHD in adults. I'll give you an overview. And finally, relevant new research. Around 1580, 1590, Shakespeare talked about ADHD in one of his characters in Henry IV. And he said for John Falstaff, he talked about having the disease of not listening, the malady of not marking. It's pretty amazing. And then it turns out 1775 was a great year for ADHD. We have a German physician and a Scottish physician, and they both differently observed people who cannot pay attention, who cannot sit still. And if you look at the Sir Crichton's description, it's pretty fascinating how careful he was in his observation. And toward the end, he says, what is very fortunate, it's generally diminished with age. If you look at the 20th century nomenclature on ADHD, you will see various terms, right, including defective moral control, organic dryness. You'll hear minimal brain dysfunction. There are still physicians and other providers, by the way, use some of these terms. Hyperkinetic child syndrome, and finally, ADD, or attention deficit disorder. I won't spend much time on this. Dr. Schweitzer and Dr. Dixon did talk about this briefly, but we have the genetic factors and environmental factors. If you look at the environmental factors, you will see items such as exposure, postnatal exposure to lead, and low oxygen states. Dr. Schweitzer briefly talked about this. I still hear this every week in my clinic. So is ADHD real, doctor? There are several reasons that we should probably consider it is. Because of the genetic background, structural brain differences, again, Julie talked about that a little bit, long and consistent history. We have the presence across cultures in many different continents. We have the diagnostic validity and similarities but differences in outcomes over time may or may not be related to the treatment. We'll talk about comorbidities briefly. This is from Dr. Jansen, modified slightly. I use this slide because I think it's so clear and it captures some of the important elements, certainly not all the comorbid features. You'll see here huge conduct disorder plus oppositional defiant disorder. And it will be really important. It will have some relevance for people's choices in the future. Significant chunk there, anxiety disorder, and others. What are those others? Increased risk for suicide, both attempts and ideation. Why is that important? Because if there's comorbidity with depression, for example, you really have to monitor the individuals that you're working with for suicidality very carefully. Increased alcohol, marijuana, and nicotine, and earlier use of these three items. If there is ADHD plus conduct disorder, you also have increased risk for use of hard drugs, cocaine and everything else. So we have to be really mindful about the comorbidities. Now, bipolar disorder is very interesting, and I know some of you are very familiar with this. If you have bipolar disorder, you have a very high risk of having ADHD. Depending on the studies, it goes from 30 to 65, 70%, some US, some European studies. But if you have, it's almost one-way street. If you have ADHD initially and you're looking for bipolar disorder in that population, it appears to be lower. And certainly autism spectrum disorder, now we have DSM-5, and we can diagnose those two conditions separately. This is, I'm not going to spend much time on this because Dr. Dixon did a fantastic job with her fancier slide than mine, but I think this is a pretty nice slide too. It gives you a nice lifespan approach and some of the difficulties starting from birth all the way to the adulthood. This is from This slide is from Dr. Collins, adapted from Schmidt. Psychiatric assessment of ADHD, previous presenters really talk about this, so I won't spend much time, but we have to be careful. If there is significant medical concerns, it's okay to order certain labs. And there are some studies that we're trying to get one started too, that looking into metals and both ADHD and ASD. This is the multimodal treatment of ADHD. Again, the previous presenters talk about this, but you have the biological treatment and medications. You have school-based or workplace-based supports. They are just as important. We have behavioral therapy options. And finally, additional treatments, not alternative, but complementary treatments. Is everybody with me still? We're doing okay? Great. Medications. This is from Barkley. It's a fun slide. It's a very simple but very inclusive slide that I like to use it because it sort of summarizes the stimulant story for you. Stimulants and non-stimulants, methylphenidate and amphetamines. And if you look at the stimulants, it will be duration of action, very simple, short or long, right? It's pretty simple, pretty basic, but it really explains. Non-stimulants, there aren't many of those either. You have the norepinephrine reuptake inhibitors, such as atomoxetine. We have the alpha agonists. We'll talk about those briefly. And very old, but still valuable for a subgroup of patients, TCAs or tricyclics. This is a stimulant medication table. If you look at I included some commercial names here because they may have the same active substance, but they will have completely different delivery systems. Two medications may have the same active substance, completely different delivery, one from 1950s, one from 1990s. So it's important for you to realize that. And sometimes it's okay to argue with your pharmacist or the plan if they are pushing you for an older technology for delivery, because the side effects appear to be much better in newer, more consistent technologies. Short-acting stimulants are less used these days. We, for the most part, start with longer-acting stimulants and maintain the treatment with that, but short-acting stimulants may have a place in treatment. Mostly for sensitive individuals, or we can have some brief trials sometimes. There is a group, they are longer acting stimulants, but we call them intermediate really because they are shorter acting than much longer acting options, and they seem to have dual pulse. So they have this biphasic appearance. Right in the middle of the day, around noon, the blood level will go down, and some parents feel that it helps with the kid's appetite. This applies to adults as well during the lunchtime. So it may be a valuable tool because they are not as long acting. If there is a sleep issue related to stimulants, they leave system earlier, they may be reasonable as well. Most of the patients, though, will require long-acting stimulant medications for best outcome in terms of medication treatment. I will very briefly touch upon the common side effects. Most of them will be mild and temporary. However, if you keep stopping the medication every third, every fourth day, or every weekend, the side effects will return when you go back on the medication, as if you are taking it for the first time. Does it make sense? Atomoxetine, very briefly, it's the first non-stimulant approved by FDA for treatment of ADHD. It may be a really good choice for maintaining a 24-hour blood level for individuals with comorbid anxiety and tic disorder. Be careful, it may cause some liver injury, so it may be reasonable to monitor the enzymes. Non-stimulants, these are interesting group of medications, centrally acting alpha agonists. There are only two of them, guanfacine and clonidine, and of course, extended release options. Extended release options are great. Why? Because they don't have this rebound increase in blood pressure when you forget to take the medication. I remember I had a patient, wonderful family, trip to Hawaii, they forgot to take their medication with the boy, young man, ended up in emergency department because of the significant increase with the blood pressure. Now, that is especially with short-acting clonidine there. Happens less with guanfacine. With extended release options, you're not likely to see that sort of dramatic rebound effect. Guanfacine extended release appears to be a really good medication, well studied in children and adults now, but the dose requirements may be higher than initially thought to make a difference with executive function and impulsivity. I love this slide because it's a scorecard for the main medications. 1 to 10, methylphenidate gets an 8, not bad. Strattera, 6.5. Clonidine and guanfacine, they are both close to 6. And we have a complementary item there, omega-3. Turns out that it scores higher than placebo. And we'll talk about complementary strategies more later. This is a special population I want to bring up because preschool age children can be treated with medications, but we have to be very careful with the comorbidities, and the dosage needs to be really very carefully fine-tuned, and the lower the better in our experience. Adults, now this is going to be fun because there are wonderful new studies around the world. Look at the long-standing patterns. We have patients, we have a recent patient from the Bay Area. She showed up for the initial visit with years of teacher reports and comments, these teachers writing about, from elementary school, about her being so brilliant yet having all these problems, sitting still and waiting for her turn. That is really helpful to us diagnostically. So keep those old records. Comorbid conditions need to be addressed, and they are very common in adults. Anxiety, substance issues, depression, bipolar disorder. Unless you work with those issues and address them, your ADHD treatment with the stimulant medication alone will likely to fail. It won't be successful. Adult checklists are very helpful. Dr. Schweitzer talked about this. And vocational support is just like 504 or IEP for children. It can be crucial, needs to be utilized if available. All right. This is we'll talk about the medication treatment for adults in ADHD with some new studies. One of them is very recent from Spencer, and they looked at methylphenidate versus placebo in adults. These are 25 and up. It's an older age group, and the response rate was 76%, 19 of placebo. That's a really very significant success, and it wasn't really so much dependent on the socioeconomic status or the gender of the patient or even comorbid condition. That's hopeful. Saffron study looked into medication plus cognitive behavior therapy. The previous presenters talked about CBT a little bit. Dr. Dixon mentioned that. And it appears that when you add CBT, indeed, it lowers anxiety symptoms than other comorbid issues such as depression. It's important to take advantage of that individual therapy along with the stimulant medication. Finally, they looked at Whelan's group, Tim Whelan's group looked at the atomoxetine in adults with chronic alcohol issues, and ADHD symptoms really improved in the study, but it turns out that the alcohol use behavior did not improve as consistently. There was a discrepancy in the response. This is a very recent study as well, and in this particular study, they compare methylphenidate or Ritalin with atomoxetine. And both groups in adults did very well. They both responded to the medication. Most of them tolerated the treatment. Dropout rate in the study was quite low, and there was not much difference in terms of the adverse effects in these two groups. Group treatment for adults with ADHD, this is from like Dr. Schweitzer, one of her slides, it was wonderful. This is from last week, I think, so it's a very, they just published this, It's very recent, and it's very, I thought, creative program. It's a group treatment for adults with ADHD. It's a 14-week-long program, and they use CBT plus DBT, so cognitive behavior therapy plus dialectical behavior therapy, and it was weekly groups. And then they did 1 month and 6 months after the group was concluded, they looked at the ADHD core symptoms. And the group did great. People who participated in this 14-week program did very well and remained stable with minimal symptoms at 6 months after the study. That's really encouraging for us to maybe think outside the box a little bit and look into new options in addition to medication treatment. Depression and anxiety symptoms have also improved in the group as a whole. Complementary treatments, very briefly, I'll talk about two of them. One of them is exercise. Michael Phelps talked about how exercise, excessive swimming, and exercising 9 hours a day helped him with his ADHD publicly. Again, it turns out he was right. We think this is happening because there's a significant increase with BDNF, which helps with the central nervous system growth. It helps with synapse and the nerve formation, as well as some other mechanisms. So we are thinking that these are the important factors, but this may be one of the safer complementary strategies. Please do not overlook keeping those individuals active. By the way, high BMI, overweight status, is a significant problem in adults and adolescents with ADHD. So this is another great reason for us to consider this as probably the main complementary strategy. Omega-3, again, it turns out it's better than initially thought. If you look at the meta-analysis of, a beta-analysis of 10 studies, it scored about 31, that 1 to 100 scorecard I talked about earlier, did better than placebo, and it appears to have some benefit, not instead of treatment, again, additional benefit to the existing treatment strategies. Few relevant new, but I feel important new research. I get this question all the time, both from adult and younger patients and their families. Do stimulants cause tics? They make it worse, and what can we do about that? The studies about the FDA warning about the tics and stimulants are case report based, individual case based from 1970s. The recent studies, including TACT study, show that they looked at the methylphenidate, clonidine, and the placebo group. And out of the three groups, actually, the methylphenidate group did better than the other two, including clonidine, by the way, is one of the treatment strategies to address tic disorders. So that's very hopeful. And they looked at the 22 randomized studies, and they did not see any association between new onset or worsening of tics. So you may have individual stories, but if you look at the large trials as a whole, it doesn't seem to support that. And there was no difference between methylphenidate or Ritalin and amphetamine salts, which is Adderall group. So they were just the same. If tics emerge with stimulant medication in individual patients, despite all this data we have, trying another stimulant medication may be a good option initially, and then if it's happening, try a non-stimulant medication strategy. The second nice new research that I like, they looked at the childhood ADHD research group from childhood, and they did a follow-up study for these same individuals as adults, and they looked at their achievement scores. And these are individuals without specific learning disorders, so they have general ADHD. 10 years later, they looked at their achievement scores, and of course, they found that they had significant underachievement in both reading and math scores. And they feel that this explains both occupational and personal difficulties, or may help explain. This is interesting because we are looking at adult studies long-term. Now, ADHD studies are very different from depression, anxiety, psychosis, and bipolar disorder studies. In ADHD, we have larger data in children and adolescents, really much more limited data in adults that we are just starting to look into. With all other psychiatric conditions, it goes the other way. We have plenty of adult data. We're just starting to look into the pediatric data, I should say. ADHD and sleep regulation, another, just like high BMI, another under-addressed issue, in my opinion. People with ADHD, turns out, have a lot of sleep regulation problems. Some of them may be feeling very tired right now and bored and falling asleep. You're not alone. There is an excessive daytime sleepiness or sedation at moderate or severe level in ADHD population as well, and it's very high. It's significant, and it affects their treatment response, their day-to-day functioning, and even their driving, according to this study. It's really significant. And by the way, if you talk to clinicians who work with individuals with ADHD, they will tell you about the excessive daytime sleepiness or sedation issues. But now it's published, and there's some studies supporting it. I thought this was really interesting. And finally, talk about addressed issues, pregnant women and ADHD in this group. Very limited information. They looked at the ADHD symptoms in this group and self-reported, and they looked at the occupational or professional relationship, and finally daily functioning scores. Now, they did this with depression, they did this with anxiety, but nothing, if you look at the pregnancy and ADHD, its impact, there was nothing up to this point other than case reports. So this is really significant. And they found out that there is indeed a significant association between having ADHD and level of functioning and difficulties in women who are pregnant. Inattentive symptoms, you'll see at the bottom, inattentive symptoms were significant predictors of professional life impairment, daily life impairment, and relationship. And the impulsivity uniquely predicted variability in professional life impairment, as well as personal relationship impairment. I think it's very important for us to pay attention and address the issues in this population. Again, this is a population that we rarely discuss ADHD with.